We'll wait a moment here for folks to join our meeting. Welcome everyone to our summer health policy series. Today's panel is on promoting housing stability through health policy. And I am delighted to have joining us today, Nina Janopaul, who's president and CEO of the Arlington Partnership for Affordable Housing. She also serves on George Mason's Innovation Advisory Council, formed by our President Gregory Washington. So she's part of this group of forward-thinking regional business executives and community leaders who are providing strategic guidance and advocacy for the university's Arlington Innovation Initiative, which is a corridor in our county. We also have with us Shira Hollander, who is Senior Associate Director for Payment Policy at the American Hospital Association. She develops and advocates for policy positions regarding value-based payment arrangements and also social determinants of health and issues related to physician payment. And Anna Cleveland joins us from the Agency for Healthcare Administration in Florida, which is their Medicaid agency. She is a government operations consultant and is in the specialized services unit and a subject matter expert on the Florida statewide Medicaid managed care housing assistance pilot. So thank you, all three of you, for joining us today. We are delighted to have you offering your expertise on this very important topic. And in fact, we wanted to start with Nina, if you would please. What I also want to encourage our audience, you have a Q&A function, so please post your questions. We will have a discussion. Each presenter will talk for a bit, have formal remarks, and then we'll open it up to a moderated Q&A discussion. So Nina, if you would please help us understand what does housing look like?
Well, thank you, and good afternoon, Allison. Yes, housing is a national crisis. We haven't built enough housing, and we haven't built enough housing that's affordable for the bottom 40% of our population. So we are struggling nationwide, and the partnership with, we all know that housing is a social determinant of health, and that when people aren't stably housed, they're not healthy. So that's been part of my mission and my work for the last 20 years, and I'm excited to be here. Do you want me to jump in? And
I think we should go ahead, please, and go ahead and jump in on your remarks. I appreciate that. Mm-hmm.
Okay. Hopefully this will work. So I have the honor of being the president and CEO of the Arlington Partnership for Affordable Housing. I've been in that job for about 14 years, and we have about 2,000 apartments. We're based in Arlington, but we work throughout the Washington metro area. Do a page down. Yeah. We're a nonprofit organization considered one of the top 50 affordable housing developers in 2019. And as I said, we have 2,000 apartment homes now and another 1,700 in development. So we're doing our best to grow to meet this tremendous need. Our portfolio has a value of about $500 million, $500 million. And as a nonprofit housing provider, we not only provide safe and secure affordable housing, but also services and programs for our residents. And that's an important component of our mission. About 10% of our units are targeted to people who are formerly homeless and persons with disabilities. This is part of our commitment to permanent supportive housing. We partner with others that provide the wraparound services for these residents, which may have folks with serious mental illness, people coming out of homelessness, folks that have developmental disabilities and need caregivers. This is a real effort to mainstream those populations and let them have an opportunity to live in the community. And as I said, we work throughout the metro area. I wanted to start just talking about the continuum of housing. So this is sort of organized by those least affluent in our community to those most affluent. So where do people live if they have no money and no resources? They live on our streets, or frankly, in our emergency rooms or our jails. Living unsheltered, one might think, is actually very little societal cost. It's actually a very high societal cost. The cost of picking people up, putting them in jail can be $50,000 a year, and people cycling in and out of the emergency room can be hundreds of thousands of dollars. So there's been a big commitment in our work and area to end homelessness as we know it. It's a societal good, it's a humane thing, but it's also an economic benefit to our government and our communities. Sort of the next step up from there is the shelter system. This used to be sort of the preferred way of housing people out of homelessness. And there was a big initiative, actually more than 10 years ago, called Housing First, which said shelters just prolong the problem, takes people off the streets. They have maybe hygienic opportunities and heat and air conditioning in the summer, but they aren't moving forward with their lives. And we know that if we put them into housing first, they can then stabilize their lives. So permanent supported housing, which, as I said, my organization, APAH, devotes about 10% of its portfolio to this work, is really considered a best practice and a way to get people off the streets and moving forward in their lives in the best way possible. And the phrase permanent is a really important piece of that. Shelters were often seen as transitional housing. This concept is some people may permanently need to have housing subsidies as well as wraparound services due to whatever their limitations are. The next step up in this chain, and there's not nearly enough of this, is subsidized housing. And we have basically two delivery tools in the nation for that. One is the public housing network. We have public housing authorities all over the country. Most of them saw their heyday during the Great Society under Lyndon Johnson and haven't been adding a lot of units since then. And they're terribly underfunded. Recent administrations have tried to make a dent in it. The current pay estimate for bringing our public housing up to contemporary standards is $800 billion. And in the new infrastructure bill, there is a proposal to fund half of that. I will say in a typical administrative year, they talk about funding 1% of it, maybe 5% in a good year. So this is a very dramatic opportunity to reshape the face of public housing. There's been some other tools of redeveloping public housing, so that's not the only tool, but the important thing that this audience might want to know is 1 out of 4 persons that are eligible for either public housing or housing choice vouchers, that is, that are eligible for a rent subsidy, only 1 out of 4 get that subsidy. This is an incredibly underfunded resource. The housing choice voucher was developed more in the 80s. Instead of having all of your subsidized housing in designated buildings, the concept was that these would be portable, that a tenant could take their housing choice voucher and go wherever they wanted to live. And that's a big part of this program. But again, together, those two programs only serve about 25% of the households that are eligible. The next step up on the rung, a space that APAH spends a lot of time working on, is committed affordable housing. And the biggest tool for that is the low-income housing tax credit. It's produced 3 million homes across the United States since it was inaugurated during the Reagan administration in 1986. And while it isn't the same as subsidized housing, where you pay a percentage of your income, the designation is that it has lower rents. So it's designed to be more affordable by having rents. For example, here in Arlington, our properties are typically half of the market rents. So people can live in a stable environment where they wouldn't otherwise find affordable housing. Another component of the housing continuum is market affordable housing, or sometimes it's called NOAH, naturally occurring affordable housing. These are often aging apartments, Class C apartments, mobile homes, I would put often are in that category. And they're affordable, but not by design or financing, but frankly by age. And what's happening is, again, with this national shortage of housing, we're finding that that housing stock is dwindling and becoming more expensive. we call it the value add part of the capital investment market. Investors buy these old Class C apartments, fix them up, and double the rents. So increasingly, that's not available to low-income households. And then an important piece of the housing stock is just the market rental housing, which we often say serves people from 80% of area median income. In DC, that would be $80,000 a year, up to 120% of area median income, or about $120,000 a year for a family of four. That's an important component of the market, as well as increasingly we're seeing a lot of single family homes in the rental space. So investors buy up single family homes and rent them. And then of course there's home ownership, both condos, co-ops, and single family homes, which I think are a majority of Americans, but less than they were before the Great Recession in 2008. Now, what can we do to create more affordable housing? And the most important thing are these funding tools. So as I said, the low-income housing tax credit, LIHTC, we lovingly call it, is a federal program that provides private equity, typically from banks, that subsidizes the low-income housing. About 3 million homes have been created, and a couple of recent administrations have strengthened this program, and there's legislation to boost the program again, currently in front of Congress. State resources are an important component. More than 35 states have housing trust funds. They have other programs like state housing tax credits that mimic the LIHTC program, the federal LIHTC program. They also use tax abatements, and these are key. Often projects that we develop have layered financing. They might have a federal piece, a state piece, and then a municipal piece. A lot of municipalities have realized that their workforce is contingent on having affordable housing. People can't live. Loudoun County here in Northern Virginia, the Chamber of Commerce voted to say we need a local housing trust fund because we need more affordable housing. We can't find workers for our service jobs, for our retail workers, for our construction workers. And we don't want them to be commuting an hour away and be unreliable. We want them to be part of our community. Another important piece of this, and a growing piece, is philanthropy and partnerships. And I do want to note that Kaiser Permanente has a really leading edge $200 million commitment to their Thriving Communities Fund to invest in affordable housing. And that gets us to that link between housing and health. Sorry, one more quick slide here on other tools. Another tool is land use. We can't do new affordable housing. Frankly, we need land use tools for all of our housing. And we're finding as a nation that there's a lot of community resistance for density and for more development. And the honest truth is it's either going to be sprawl or it's going to be more density. There's no other choice. Our cities are growing, and either people are going to live on the edge and drive an hour in and add to our climate footprint and add to our congestion, or they're going to live, as this illustration shows, in more mid-rise and high-rise buildings. These are a couple of projects that my organization built, actually all three of them on top of buildings that previously were 1 or 2 stories. So this is a way that we need to create more housing stock, and particularly for affordable housing. We've been doing things like redeveloping our existing garden apartments, working on public land. We have a very innovative project in Fairfax that is going to be built on a stormwater site. So finding places where there's land that's underutilized, partnering with civic organizations. I'm very proud we're working on our 3rd faith partnership, hope to break ground on that later this year. And actually one of the first in the nation, we partnered with an American Legion post, and they are going to have a new post on the 1st floor, and we are going to have 170 units of affordable housing on top, which will have a veterans preference. Another piece of this is partnering with groups that are doing for-profit market developments. We're doing one project with Erickson Senior Living. They have a 65-acre campus in Fairfax County, and they're setting aside 3 acres of that for affordable housing. And I think there's some models that have done that with hospital campuses as well. As I said at the beginning, another piece of what APAH focuses on is services with and for our residents, and nothing brought that home more than COVID-19 and the impact of having a pandemic. All of our residents were impacted by that. Many lost their jobs because they weren't working in the kind of jobs where they could do Zoom from home as we're doing today and serve on panels. They were restaurant workers and Uber drivers and salon workers, which were all devastated during the pandemic. Our program aims to bring trauma-informed and resident-driven services. So we work with our residents to see where they are and what they need. We have staff that are always assessing their assets. We want to do this from an asset frame. What's working well for them and how can we help them do more of that? And to coordinate with partners in the community. And another piece of what we do, just to add to our mission here, is bring up that resident voice. And we know so much that the underserved in our country are also often the underheard. Housing is a social determinant of health. This is the point of this conference, right? How does the work that we're doing at APAH contribute to that? Well, the first and foremost is by providing safe and stable housing. We know when people come into affordable housing, committed affordable housing, they move less, they stay 5, 10 more years, whereas low-income people are often moving every couple of years. Very disruptive to the family, but also disruptive for children and their lack of continuity in school. They're also moving into committed affordable housing is free from hazards. Unlike some of that Class C aging housing stock, we're very strict about things like lead paint and mold. And we also think about things like trauma-informed design. How can we make a setting that will be comforting and helpful for folks who have been through a lot of difficulties in their lives? Second piece of what our organization focuses on is moving our housing in places of high opportunity. There is too much poverty that is clustered. We are a nation of division, racial division and economic division. So if we can bring, for example, this image here is of our project that we did in partnership with Arlington Presbyterian Church. We're surrounded by single family homes that are worth almost $1 million. What a great opportunity for apartment renters to live in a low crime, mixed income community with high performing schools. We're right on a bus line. We're walkable to public transit as well as the metro down the 1 mile down the street at the Pentagon. And we have grocery stores, libraries, and other amenities nearby. So those high opportunity neighborhoods can make a huge difference in outcomes for families. And then, as I was just talking about, service enriched, to have community spaces in our buildings, fitness centers, playgrounds, business centers, programs that we work in partnership. So I think those are all things that are an important piece of how housing can help with health outcomes.
Thank you so much for that introduction. These are two sectors that are both incredibly complicated to understand, how healthcare is delivered, how it's financed, and I think housing similarly. So Shira, could you please talk to us a little bit about your work at the American Hospital Association and how hospitals are coming at this particular social determinant of health? And again, thank you for joining us.
Yeah, thank you so much for having me. And I'm just on the other side and on Chevy Chase, but now I want to go check out all the properties that you just displayed. Those look really beautiful. So I think, as Allison said, there's sort of two questions that I want to explore with all of you today. First is, what is the role of hospitals and health systems in contributing to this housing crisis? You could view the housing crisis from the homeless individual who presents to the ER because they need a meal. You could view it from the level of the developer who has to build affordable housing, contractually obligated to do so alongside their skyscrapers. Or you could see it from the level of the policymaker that's trying to undo the structural racism that's resulted in housing shortages, redlining, all those sorts of issues. So I think there's a key question before you want your neighborhood or your community hospital to get involved is, at which of those levels would it be most beneficial for patients and providers and communities for hospitals to get involved? So that's the first question. And then the second question I think we should look at is, what's the current policy landscape? Does it enable this work at the hospital level while maintaining and protecting a hospital's ability to develop their core business, to execute their core business, which is to provide high quality care to every single person who shows up at their door? We want to make sure that we don't lose that efforts from hospitals as well. Next slide, please. So just a quick overview. Nina sort of touched on this already, but take a quick look at the societal factors that influence health. Look at the connection between health and housing, the role for hospitals and health systems, and whether the current policy landscape enables this work. Next slide. So I know that this will come as no surprise to anybody here that societal factors influence about 80% of our health. I think you could look at this graph and you could see housing instability as a socioeconomic factor. You could see it as a physical environment factor. But I think the most interesting thing to think about is that all things being equal, if two people receive the exact same care from the same provider and one is housing unstable and one has stable housing, they'll have completely different outcomes. So that just goes to show kind of how significantly it plays into your healthcare outcomes. Next slide. So the APAH actually just studied this recently. Over many years, we've studied the issue on many aspects, but just recently published this health and housing roadmap, which is available on our website. Next slide. So again, we know, and Nina expressed this, that the scope of the problem is vast. You know, almost half of all renters are cost burdened. As Nina mentioned, only 25% of those who qualify for assistance get it. And of course, as we know, while housing instability does impact people of all races and all ethnicities, there are inequities. There are definitely disproportional impacts to people of color, to you can see I was thinking about women-owned businesses, but women-run families, and as well for children, where it's really quite severe. And I'm happy also to share any of the resources you see footnoted here. They're in that health and housing roadmap. Next slide. So we know that this is a major problem in the country. What's the connection to healthcare? How does your local hospital administrator, your provider, the medical staff, the non-medical staff view this problem from their vantage point? Now, we know that you need a safe and stable place to sleep to be both physically and mentally healthy. And in fact, not having stable housing can take almost 30 years off somebody's life. I mean, that just blows my mind that the average life expectancy for somebody with unstable housing is 27.3 years less than somebody with stable housing. So we're talking about really sort of generations of children without parents and so many other people that just their lives are made much shorter by the lack of stable housing. So let me just share some statistics with you about how this kind of impacts healthcare and the provision of healthcare. A third of all ED visits are made by individuals who experience chronic homelessness. Individuals experiencing homelessness visit the ED an average of 5 times a year. Patients without stable housing are 50% more likely to be readmitted, and 80% of ED visits by individuals experiencing homelessness are for preventable illnesses. I think if you're familiar with any of the emergency departments here, I've had to make a trip with my daughter to Children's. They are very, very, very crowded. So the idea that 80% of the visits could be avoided, I think would be very welcome news to emergency department administrators. Next slide. Okay, so we know that there's a problem. What do we do about it? What's the solution? What's the answer? And I think the most important thing to note is that the answer really depends on what the community needs. Hospitals are always looking to partner with the knowledge experts and the people in the community that really understand the needs. There are common approaches that Nina talked about, but the driving factor should be the expertise in the community. This slide, this image gives you some idea of who some of the partners can be. There's a lot of private sector opportunities with banks, developers, entrepreneurs, insurers, and then there's public sector. There's philanthropy, there's state and local government, social services, a wide range of potential partners. So I'm not going to talk today about how to determine your community need. I think that's a little bit beyond the scope, although AHA does have resources if anyone's interested, but I am going to share with you an AHA developed framework that was meant to help hospitals start these conversations. And I just included the statistic about the $1.6 billion that hospitals have invested in housing related interventions to say, in some places this work is well underway, in some places it's just getting started, and in some places, we're hoping to help launch the work. Next slide. So this is our societal factors and influence health framework. And the idea, again, is to support hospitals on their journey to addressing social factors, of which housing is one of them. So let's walk through some examples at each of these levels. Next slide. So the kind of most narrow level, the person level, are social needs. These are an individual's non-medical, social, or economic circumstances that prevent them from staying healthy or from recovering from illness. Clinicians learn about these at the point of care. There's many, many hospitals, I think it's like almost 50%, something like that, that screen for social determinants of health at the point of care during a patient encounter. And these are when you can learn about that individual person's housing instability concerns or issues. And if a patient screens positive, then a hospital can refer them to community resources. Next slide. So this is an example from Penn Medicine's Lancaster General Health Hospital. They have this program called LINC My Home. It's actually been around since 2009, and it is a cross-sector collaboration. No hospital believes they can do this work alone, but it is housed at the hospital. During the pandemic, they expanded their work by setting up portable bathrooms and hand washing stations, providing transportation to COVID testing sites, and providing these other services, again, that address the social need of an individual's housing situation. Next slide. If we pull it up a level, we see the social determinants of health at the community level. So these are the underlying social and economic conditions that influence where people work, live, learn, and play. If you think about this, an example of this would be, just as Nina discussed, the lack of affordable housing options in a community. So if you think about a community that has people who are housing unstable and people with housing, the instability would be the social need, and just the lack of affordable housing for those individuals would be the social determinant of health. And this is a place where hospitals can really work with partners to identify community needs. They can invest in housing development, partner with local organizations, and it's a level at which it seems to be kind of the most fertile for hospitals to be involved. Next slide. So this is an example from Nationwide Children's Hospital in Columbus, Ohio. Nationwide worked with many partners to create the Healthy Neighborhoods, Healthy Families initiative. It's about a decade old. Again, cross-sector collaboration housed at the hospital. They take on a lot of issues, but specifically with regard to housing, since they launched, they have added or maintained 315 affordable housing units, and they're seeing dramatic results. Violent crime is down, the graduation rate is up, and they're also already seeing early declines in the cost of emergency department care and the utilization levels for children. So they're seeing social impacts, they're seeing housing impacts, and they're seeing health impacts from just 10 years of this work. Next slide. Going up one more level, this is sort of the more macro level. These are the systemic causes, the fundamental causes of social inequity that lead to poor health and inadequate housing, like racism and poverty. Of course, no hospital, no single entity can solve these alone, but in partnership, I think there's a lot of potential to address these issues. Next slide. So I want to share an example. This is Trinity Health's Transforming Communities initiative. It's not specifically a housing focused entity, but it does kind of give you a sense of policy and advocacy work that can have a real impact here. So TCI has influence for public policy in many states. They've identified youth smoking and childhood obesity as two of their main issues. And they've advocated for changes in laws that have occurred in 7 out of the 8 states in which they operate to raise the minimum age to purchase tobacco. And of course, they're looking for long-term health impacts, graduation rates, all those types of things that will be trickle-down effects from adjusting these macro causes. Next slide. So I just want to pause here for a minute and identify that there's probably going to be situations in which a hospital cannot or should not be a real estate developer, housing provider, play any of these other roles that we talked about. That may not be their expertise. It may not be what a community needs. And it might just not be the appropriate role in a certain environment. But it's really important in that case to remember that hospitals have core business roles that can have an impact here. So for example, we'll talk about this a little bit more in the policy section, but hospitals are great referral sources. When somebody comes in for medical care but has unstable housing, a hospital can connect that person to a navigator or someone who provides social services. They're employers. They can choose to pay a certain wage that would allow employees in that community to afford housing. Hospitals are also research institutions. They can study and publish on the impacts of insecure and unstable housing to secure more funding from a local government, for example. And they're also consumers. Hospitals could agree only to work with a developer who also agrees to build some affordable housing. They can use their market power in many ways other than just the ways that we talked about before. This is a little bit more behind the scenes. I think it's probably not what we generally think about when we think about improving the housing supply in a community, but because it is part of a hospital and health system's core business, it really does set them up for success in this realm. Next slide. So let's take a look at the policy environment. There's federal opportunities and then some state-based opportunities as well. Next slide. So the American Hospital Association is part of an organization called Aligning for Health. It's a multi-stakeholder collaborative, and the idea here was to enable social service providers to wrap interventions and wrap funds around Medicaid beneficiaries. So the ultimate goal is to provide funding for state and local governments to come together with all their stakeholders in order to create a targeted intervention. Let's say you're looking at homelessness among pregnant women, and then have the authority and understanding to blend and braid funding from federal programs without touching Medicaid dollars. So that's kind of the long-term goal of Aligning for Health. Last year, we were successful in getting the Social Determinants Accelerator Act introduced. This is the kind of planning grant stage of that work. It will help states leverage existing programs to do so. The request in that bill was for $25 million. Parts of the bill was included in the fiscal year 21 consolidated appropriations package for $3 million. And CDC is actually now kind of at the executory stage of this. There was a significant endorsement in President Biden's budget for fiscal year 2022. He asked for another $150 million for this and other programs. And then in the current Congress, this SDAA Social Determinants Accelerator Act was reintroduced. Next slide. Aligning for Health also developed the Leveraging Integrated Networks and Communities, or LINC Act, to address social needs. This is more about kind of propping up and based upon collaborations that are already happening at the state and local level. And the bill is meant to provide for better coordination of care between healthcare providers and social services organizations through statewide public-private partnerships and other approaches to making sure that care is coordinated. So this is a bipartisan bill in the Senate. We're currently waiting for a House companion. Next slide. There's tons of pending legislation that supports initiatives and organizations addressing housing insecurity. I'm providing a few examples here of things that hospitals could take advantage of, but there's many, many more that are sort of unrelated to the connection to healthcare. There's several bills that look at improving housing for veterans. These interestingly work on better connecting veterans' medical care and their health and their housing through providing certain information to VA medical centers. So it's very targeted, but has the potential to have quite a significant impact. There are some other bills that address better coordination of healthcare and housing, like the LINC Act that I just mentioned. And finally, there's bills that provide incentives to build affordable housing that a hospital might be able to take advantage of, like any other building organization. Next slide. On the sort of administration regulatory side, in the Centers for Medicare and Medicaid Innovation, there is a demonstration model called the Accountable Health Communities model. This is a navigation model. The idea is to screen for health-related social needs, of which housing is one, and then refer patients who screen positive into a sort of navigating system to get them connected to the resources they need. And the ultimate goal is to bring down healthcare costs by doing this. It's too early to tell whether that goal is being achieved, but interestingly, in the initial evaluations, we did see that there's a lot of need. And for those who do qualify for navigation services, a large majority are accepting them. So we're hoping that that will show and eventually produce a reduction in utilization of healthcare costs, because people will begin to get the social services they need and become healthier. Next slide. There are also several Medicaid examples. I'll just caveat here that neither I nor AHA are really Medicaid experts. There's Medicaid is very different in each state, and we really defer to our state association colleagues on that. But I just wanted to provide a few examples of hospital work here. Hennepin Health is a navigator model similar to that Aligning for Health. Similar to the Accountable Health Communities model. It's county administered, it's a partnership with the hospital. And again, this is a place where the hospitals can refer people into the navigation system, and that's a really great role for them to play. Medicaid ACOs have also done more here than Medicare ACOs. I think it's got a lot to do with the fact of the population that Medicaid serves, and also the flexibility and state authority that federal authority does not have. So the Camden Coalition is an example of a hospital-led partnership to integrate housing and health. It turned into an ACO in Camden, New Jersey. And again, that's a place where there's been a little bit more flexibility. And then there's also a waiver referred to as health homes. And it's very different in every state. It involves the coordination of healthcare and social services. And for example, in New York, the state has required that health homes have sort of a wide-ranging team that addresses housing needs. So they've prioritized addressing housing needs alongside health. Next slide. And finally, I'll just share this letter. This is a state health official letter that went out to health officials in states outlining current opportunities in Medicaid and CHIP. So as I mentioned, Medicaid's kind of a little bit more advanced here, and they're really trying to keep this policy environment moving. This letter describes the categories that state Medicaid agencies can use to address health-related social needs, such as housing, and just give some states some ideas on using managed care, on using alternative payment models, and some of those ideas are specific to housing modifications. So I'll stop there, and I'm happy to take any questions.
Sure. And in fact, I think what we'll do, since you've teed up the Medicaid topic so beautifully, is we'll turn to Anna Cleveland now, who is from the Florida Agency for Healthcare Administration, which runs their Medicaid program, and talk to us a little bit about some of your novel initiatives in Florida Medicaid and how you chose Housing First, for example, among the menu of things you could have done. Other states are, for example, providing vouchers for shelters for 30 days. Sort of how did you land on that one, and what other things might you have in the works?
Yes, thank you very much for having me, and thank you for that setup for Medicaid, because what Florida has done is they are using the 1115 waiver, the flexible services, to allow to create a pilot program for temporary housing assistance. It's focused on a narrower population because while we're focusing on homelessness, we're also focusing on people who have severe mental illness or substance use disorders, or a combination of both, and then are homeless or at risk of being homeless are the requirements for participating in the pilot program that is run by our statewide managed care program. So there was approval by Medicaid or by CMS in March of 2019, and then the pilot went live in December of 2019. And so this pilot is aiming to provide the additional behavioral health services for the category that was mentioned before, enrollees that are 21 and older with severe mental illness, substance use disorder, a combination of both, and who are homeless and are at risk of being homeless. So we've set it up. It's limited to 2 regions in the state right now. It's in Region 5 and 7, which include Pasco County and Pinellas County, and then Region 7 that is Seminole, Brevard, and Orange and Osceola County. Those are kind of across the middle of the state for people not as familiar with the geography of Florida. And so there was an application process, and there are 4 health plans that are participating. They've agreed to provide these supportive housing services and to work with the community partners, housing coalitions to help these individuals. So when individuals are enrolled in the housing pilot, they receive the transitional housing services, tenancy sustaining services, mobile crisis management, self-help, and peer support. And there is an opportunity for a one-time incidental payment that is provided by the health plans. This is not required. For examples of the tenancy sustaining, this is helping people be good tenants, education on training on the roles, rights, responsibilities of tenants and landlord. Once the housing is secured for them, how to reduce the risk of eviction, and those type of things. Transitional housing services, they will help the individuals find housing, set up how they're going to pay for housing, and help with moving in and making sure that the environment is safe. For mobile crisis, this is if the individual is experiencing an acute crisis with their substance use or mental illness, then these people will come out to them and maybe they can handle the situation there. and help people not be evicted from their housing, because sometimes that is an issue of people with these health conditions. There's also the self-help and peer support, which is person-centered service promoting skills, for coping with and managing symptoms while utilizing the natural resources, and the preservation and enhancement of community living skills with the assistance of the peer support specialist. And then, as mentioned, there was the one-time incidental, which is paid for by the health plans to help with a deposit or utilities. So then we kind of set up the program so that the health plans are the innovators. The agency is providing the guidance and the requirements, of course, which comes from the CMS approval, how the waiver works. There are certain things that are in the waiver that the agency agreed to do, and the CMS has approved to allow this flexibility in this health service. So we started the pilot, give you kind of how the course of the pilot has gone. It went live in December 2019. And so they started, was a totally new service for Florida Medicaid. So the health plans were working locally with housing providers, mental health providers to set up and recruit individuals. So they started enrolling people in December. And so they have been slowly increasing over every quarter the enrollment, the number of people participating. The average age of the person participating in the pilot is 46, and the majority of the participants are in the 41 to 60 age group. This program is set up to be very case management heavy. They have a case manager, housing support, to help the people navigate the housing and health system, which can be very complicated, as you all know, especially when you are dealing with these two health conditions. So we're continuing, mostly the services that have been provided in addition to the case management are the Tennessee sustaining and the transitional housing services. And the agency is continuing to review and monitor the process as this is new. COVID-19 has been a challenge with everything over the past year, but definitely with the pilot, because of the population that it's focused on. Many of the people are difficult to reach when you can't go and search for them face to face. They may not always have phone availability. So that was a challenge. The health plans, found ways to work with the individuals and the providers. There was some telemedicine that was approved, but during the public health period, or health emergency, sorry. But that's also may be difficult for some of the individuals in the program. So they have returned to many face-to-face. But despite the challenges, the health plans have continued to enroll individuals. And as this whole presentation has been about, a big challenge is there is limited availability of affordable housing, especially in the Central Florida area. And there are, for the providers that are partnered with the health plans and the agency, are working very hard to help the individuals and get them into the stable housing, but that has proved to be a challenge. And the health plans are working on building their networks. And so while we're dealing with the limited supply, bringing more people in. Medicaid is a large, complicated policy, and this requires working with housing coalitions, the local managing entities. Some of them have not been involved with Medicaid before, and so that is can be intimidating when you're first trying to figure out the system. But there have definitely been successes with the housing pilot, as it's only been going on for a year here, including the COVID year. They have been continuing to enroll new people. It has increased over each quarter, and there has been one of the performance metrics, of course, is people utilizing the ER as kind of a doctor's office is not providing them the best health care, and it's very expensive. And so nobody's really benefiting from that. So there has been some reduction in that And so the agency is continuing to, work with the health plans as they have questions, but they've definitely been reaching out and working hard to get the pilot going.
That's excellent. So it sounds like the Florida Medicaid program started with some of the more complex housing structures, the permanent supportive housing, which I should say I serve on the Community Preventative Services Task Force, and we do evidence-based reviews and have recommended permanent supportive housing with Housing First, meaning it's not conditional on, let's say, recovery, specifically for people who are experiencing homelessness and have a disabling condition, a chronic condition, or HIV, or substance use, or serious mental illness. So I wanted to open this up for questions, and I'm going to take the liberty of asking one of Nina. Hearing that Medicaid agencies are interested, and North Carolina has initiatives around this, and then so they may be furthering this agenda through their managed care organization contract. So if you're having a dialogue with managed care organizations in your community and they're interested in being able to offer this range of housing services, what kinds of questions do you have for the managed care organization? What do you need to know to be able to support this joint effort?
We really love working with folks that have high housing needs and high barriers and making that possible for them. I guess from the managed care perspective, what we would need is, we are housers first and foremost. So we need to know that the managed care organization is there for those residents, that we have, for example, a 24/7 hotline that we can call and say, our resident is in crisis, can you come and address that? We'd want to have a caseworker that is in touch with our housing staff on some kind of regular basis, at least quarterly, so that we catch behavioral issues. They notify us if there are going to be challenges that we should be aware of. Again, we aren't healthcare providers, but if the healthcare provider is really wrapping themselves around that resident, we'd love to house them.
Excellent. And Shira, this topic of land use came up, and of course that is near and dear to the hearts of hospitals as well, that are looking for sites and deal with certificate of need, for example. So where have you seen some good collaborations around land use and planning that addresses health and housing?
Yeah, so I think a really prime example comes from ProMedica in Toledo, Ohio. ProMedica's led by Randy Ustra, who's really just an incredible forward thinker in this space. And they have, I couldn't even recall all the programs off the top of my head, but that hospital system is a really good example of really going in depth on an understanding of the community needs and building out programs that way. So they really are an example of how to ensure that anything you're using, whether it's going through land use, whether you're using the community health needs assessment that hospitals are required to do every 3 years, to truly understand what is needed in the community, kind of what the regulatory environment is at the state level, and then factoring all of that into whatever type of intervention you try to execute.
Excellent. And so we have, through accountable health communities and other initiatives, a fair amount of screening around social determinants of health that's occurring on the healthcare side. And what is your take on is it the highest level homeless? Is it at what level are you seeing then the health policy pick up and try to address the need? Or is it a lower level of at risk? Or is it housing plus 3 other, food insecurity and a few others, social determinant of health flags? What is the population you see in Florida? Obviously, you've chosen behavioral health, and it sounds like homeless. In your dialogues with other state Medicaid agencies, where are you seeing that decision by and large landing?
As far as what other states are doing in addition to
in general, what your take is? Is it the homeless as the flag? Do you think that Medicaid agencies will start to look beyond the immediate homeless and the hot spotting kind of activity, or how far do you see this going?
And the first focus is the behavioral health issue. You know, substance use and severe mental illness is higher in the homeless population than the general population of the United States. And so by focusing on that part of the homeless population is what I've seen most is what Florida is doing. And there are other states that have also done the same type of waiver. There are similar is focusing on the substance use and the behavioral health with the severe mental illness. That is, I mean, the agency in Florida is focusing on that first, and then we know that people, when they're housed and they're not trying to simply survive as much, then they are healthier and they can take the time to focus on their substance use issues and the severe mental illness to hopefully be able to manage those conditions better.
Excellent. So it sounds like there is a lot of focus around this idea of something that's like either the permanent supportive housing or the housing first, certainly, and whether that's the rehousing or the permanent supportive, something in that space for a population that has fairly high health needs. And Nina, we have a question here from our audience around how important is it when you develop a site, and I realize you have lots of constraints, that there be healthcare services nearby? To what extent are you able to factor that in?
We certainly look first and foremost to be in high opportunity neighborhoods, to be transit accessible, to be walkable neighborhoods. 25% of our residents don't have cars, for example. And healthcare access is an important piece of that. We've learned that during COVID. We had a neighborhood clinic that was offering vaccine shots, but it was a couple miles away. And even after people signed up, only 50% showed up to get their vaccine. So I do think proximity helps, and having clinics nearby. We are working on a project with seniors in Washington, D.C., and actively looking for a clinic to come into the first floor so that they can be right on site. And I think that for many housing providers, that's now a best practice, particularly for seniors, but also if you have a large population of permanent supportive housing residents with high needs, a clinic right on site is a great partnership.
Excellent. And we have a question specifically around the AHA membership and their agenda. And where do you see the housing topic fitting into the priorities post-pandemic? Do you see that changing?
Yeah, so
at
I
all?
think, again, it's so important just to understand what each community needs. I mean, I'm not sure. I think the pandemic might have heightened the level of need, but I don't actually believe that it would have changed, really changed whether a community needs housing. If it needed it before the pandemic, perhaps, the amount of need is larger, but the need is still there. And, we work really to ensure our members can take action in a, that they have the regulatory and legal flexibility to take action, that they have financing. But then it's really up to them to determine what their communities need. COVID obviously stretched hospitals and health systems to a degree that no one ever thought possible. And I think one of the really big challenges that we have coming down the pike are there's a lot of burnout, and there's a lot of kind of early retirement. There's actually a lot of nurses that are leaving the field. There's very high numbers of medical and nursing school applicants right now, but the current nurses in the field are actually exiting because of the just post-traumatic stress that came after a year and a half of doing this work. So hospitals are going to be really stretched to try to figure out how they do the staffing, how they do the community outreach. But I think what the pandemic really demonstrated was how key a hospital, what key role a hospital can play for the stability of the community. So we'll have to kind of wait and see how each locale figures it out for themselves.
Excellent. And Nina, in this continuum of housing you presented, so where do you see the most activity? And if you had to guess, in crystal ball, post-pandemic, where do you see along those continuum the places where you think there'll be the most action? we did have a question, is it going to be the high-rise buildings earmarked as affordable? But where would you see the best potential for the managed care organization that's looking for a partner, or the hospital that, unlike, is really kind of amazing with the children's nationwide, doesn't want to become a housing developer themselves? Where do you see the most opportunities for common moving agenda?
I think there's great opportunities for partnerships. There are robust, affordable housing organizations like APAH all over the country. And I think, yes, hospitals, managed care organizations to reach out and to say, how can we help support your goals in whatever way possible, whether that's service delivery, joint ownership of land, financing for new housing, a closer relationship for permanent supportive housing for people in need. I think that's a great opportunity. Where do I see the most activity? Really, over the last 5 to 10 years, affordable housing has pivoted to do more new construction infill, in part to be transit accessible. Also, it's just so competitive to try and buy the older Class C apartments and preserve them, because there are other investors that are working in that space. So a lot of the low-income housing tax credit program has pivoted to do new construction. And the good news about new construction is you end up with an accessible building, brand new, very attractive. So I do think that's an exciting space to be in, and it'd be wonderful. I'm sure I speak for all my peers to have the local hospitals reach out and say, how can we be partners here?
Anna, in designing some of your policies in your managed care contract, what were some of the considerations you had to take into account around housing and how housing is delivered? Were there some things or where Medicaid can support and where Medicaid draws the line and says that we're not going to cover that under our even under an 1115 waiver? So what are some of the barriers from the Medicaid policy side?
Yes, Medicaid dollars cannot pay for housing specifically. They're not allowed to be used to pay for rent. So most of the focus of the contract was focusing on the housing services that would be provided, helping them locate housing, teaching them how to be a good tenant, especially if they're people that haven't lived, they've been unsheltered for a while. So it was focused more on kind of the behaviors, the modifications, assistance in locating housing. And then once they're in the housing, the peer support, which people who have been through the same situation that they've been and can help them navigate the system, and then keeping them housed. So if they do have an acute episode, the mobile crisis unit can come and try to keep them there. So then they're not, if they're going in and out of the ER, then that also makes it difficult to keep your house, especially if you're a lower income and dealing with the multiple comorbidities. So we're focused more on that part, not the actual housing.
Fantastic. Well, believe it or not, it's been an hour, and I wanted to thank all of you so much. Thank you, Anna, Nina, Shira, for just a marvelous session, and to our audience for your active questions and participation. And then we'll see you again for our next panel in 2 weeks. And again, panelists, thank you for joining us today.